Hello everyone, I'm Dr. Fahad from the Department of Prosthodontics who will be talking to you about abutment evaluation and selection. The learning objectives would be to understand what's an abutment teeth, to understand the biomechanical principle behind abutment selection, the clinical assessment of an abutment, radiographic assessment, the Anti's law for perisegmental assessment, and how to select an abutment for a fixed prosthesis. The following would be the contents of my talk which I will be doing. So to introduce the topic, for any success of any prosthesis, the main important thing is the foundation of it. For a foundation for a complete denture is the residual alveolar ridge with the soft tissue, whereas for a fixed partial denture it is the tooth. And this tooth we refer to as an abutment. So this abutment, if it is strong and good, the prosthesis can last for a long time. Whereas if the abutment is weaker, the prosthesis can get compromised over a period of time, however good you do it. For which I would talk to you about this teeth, which is used as a support for the fixed prosthesis, and different side headings, that is the clinical assessment of it, how do you radiographically assess it, and how do you do it on the mounted cast. So to clinically evaluate it, we'll talk to you about the crown length. The first thing which is very important is what we see in the oral cavity, that is the crown length. This crown length is the one which you can visualize, whereas the root length etc. can be seen only radiographically. So crown length is very important, and adequate length of crown is very important for success of any prosthesis. Suppose if there is no good crown length, the amount of support which is derived, or the amount of tooth structure, the retention derived from the crown, is comparatively lesser. So suppose I give an example of this. Think about a molar which has got a good height and a molar which has got a smaller height. Whenever the molar has got a smaller height, the dislodgement of the prosthesis due to lateral movement of the jaw, it is very much high. Whenever the jaw moves from side to side, that we call it as an excursive movement, the crown can come out if there is no adequate retention from the tooth surface. Whereas on the left hand side, if you see a crown length which is decently there, so the amount of rotation, that we call it as an arc of rotation, is very high. That's the reason the dislodgement of the crown happens very lesser. So good the amount of tooth structure, better is the prosthesis staying in place in what I could term. Suppose we have a scenario where we have done a short tooth preparation and we cannot compromise, because sometimes the patient doesn't provide always with a good tooth structure. In those cases, we can make sure that these problems are addressed by giving a retention groove, which is there. You can see a small vertical line over there, over here, a small vertical groove. This is called as retention groove, which is very important. It can provide single path of insertion and removal, whereas over here, because of inadequate crown length or crown height, there could be multiple path of insertion and multiple path of removal, due to which the crown can come out earlier. Then second one is placement of foundation restorations. Here we can see something called as a fiber post. This fiber post is very important whenever the tooth structure is mutilated due to caries etc. And when you place this fiber post, automatically build the crown. It could be easy and the crown will be held in place. It's like a building. When you see a building, you have a foundation, that is with railings etc. You have this beam. This beam, everything brings about support to the building. Likewise is the fiber post, or any post, cast post or metal post, which can provide amount of retention and support for the process by the virtue of increasing crown length structure. Then the other part, if you can't do this, we can do one more thing, that is crown lengthening. Now surgical crown lengthening, here what we do is the crown length is very much less. They do something called as osteoplasty as well as gingivectomy together. That's when we get a good amount of tooth structure. This surface is referred to as ferrule, which can provide amount of support, and then we can give a final prosthesis. The other way how we can improve the length of a short crown is to bring about orthodontic extrusion of the tooth, and automatically once we do that, we get good amount of tooth structure because we are pulling it coronally from the root surface. This is another way where you can have something called elastic bands, where you can have the anchor taken from the adjacent two teeth and the bands going to pull the tooth from the root surface. So I spoke to you all about the crown length or crown height. Now I'm going to speak to you all about the crown form. Crown form is a very important thing. If you don't have a good crown form or a decent amount of tooth structure, we might have a lot of compromise in our final prosthesis as well. What happens is, whenever we do a tooth preparation, we need to have a proper dimension so that the prosthesis sits properly and it can be supported well. Now, sometimes the scenarios will not always be conducive. Sometimes you might get certain situations where the tooth would be comparatively tapered. Whenever the tooth is tapered over here, what happens is we almost lost so much of tooth structure in the adjacent areas. Two problems which we can encounter is, one is the pulp horn could be very close over here, and second thing, when we do a preparation, it should be as conservative as possible. If you don't do the preparation as conservative, you might end up having the entire tooth broken along with the restoration over a period of time. And second thing, which I would ideally suggest, is we better go for something called as diagnostic wax up or intraoral mock-up. That is like putting a composite restoration around the teeth and then doing the preparation, so that we don't lose out on tooth structure as much as we think about otherwise. So crown form, a tapered crown or a peg lateral or thin incisor will all interfere with the path of insertion and removal, because the parallelism will not be achieved properly. Then comes a mutilated crown. Okay, these are also a challenging type where we need to go for a proper cover restorations, because suppose a teeth has got multiple caries, one in the mesial aspect or in the cervical aspect, it will lead to a lot of compromise. So we need to remove the caries completely. If we don't remove the caries completely, that is supposed to cause around 50 to 60% of overall fixed partial denture failures. That is the caries in abutment. Second thing is, if there is a caries which is left behind, whenever you do any tooth preparation, the tooth structure itself breaks. So we need to make sure that fracture of the abutment teeth, that is the prepared tooth, should not happen. So we need to make sure these foundations are very well anchored properly in the bone with the help of proper restorations, whichever is going to make sure that the coronal structure is well formed. So coming to the crown root ratio, what is this crown root ratio? Whatever we see, anything above the crest of the bone is called as an anatomical crown. Whatever we see in the oral cavity is referred to as a clinical crown. And whenever we do anytime assessment of crown root ratio, we do the assessment of the crown root ratio with the help of a radiograph, not clinically. We take a radiograph, we check from the crest of the bone how much of tooth structure is there all the way up to the coronal most portion of the crown, and that is referred to as crown length. And whatever is there from the crest of the bone to the root tip, that is referred to as a root length. So taking this into consideration, there are three types of assessment we can do. One is crown root ratio, which is 2:3, where that means 2 portion of crown and 3 portion of the root. So this is very much optimum, because whatever is there within the bone, the root length, that we can consider as a resistance arm, because that is going to resist any amount of force. And whatever is there that is on the coronal portion, the crown, that is referred to as a effort arm, because the effort is there, the occlusal loads are going to be there. So resistance arm, the more it is there, the better will be the success of the prosthesis. Sometimes there could be some sort of recession, so the amount of crown to root length would be 1:1, which is acceptable, but the ideal thing would be 1:2. That is 1 portion of the crown up to the crest of the bone and 2 portions of the root from the crest of the bone to the tip of the root. Second thing is the root length and form. Always remember, whenever you do all these are assessed with the help of a radiograph. Always remember, a divergent root is always better than a convergent root, number one. Second thing is, the multi-rooted tooth are better than the single tooth. So molars offer very good amount of support than that of the central incisors or the lateral incisors. Meanwhile, if we take a central incisor with a canine, whichever the root length is conical over here, it is always better to have a flat root when you take a cross section of it. If you have a conical root or if you have a round surface when you do a cross section of it, it is not good, because it can have amount of rotatory forces that can act on it, whereas a flat root is better compared to the rotatory root. So pulpal health. So we spoke to you about the crown and the root. Now we are going to speak about the biological aspects of the crown, that is the pulpal health. Pulpal health is very important whenever we think about a tooth we use for abutment selection. A healthy teeth is always better, because whenever there is a pulp, there is blood supply, there is nutrition, there is calcium, etc., which makes the tooth comparatively stronger. Whereas whenever this pulp, due to caries or deep portion which is going to involve the pulp, it causes a lot of pain, patients go for a root canal, that could be a second option. So endodontically treated teeth is a second option, vital teeth is always better. Now, as far as possible, whenever you have a vital teeth, try to maintain the vitality. It is nothing like it. If at all we don't have a vital teeth, then we can go for endodontical treated teeth. The problem is, whenever you have an endodontical treated teeth, sometimes it could lead to failure as well. So we need to be very careful. Second thing is having a good intact lamina dura. Sometimes we end up having an endoperial lesion, that is like infection going from the pulp into the periapical area or from the periodontal area into the pulp. That's referred to as endoperial lesion. This endoperial lesion leads to loss of intact lamina dura. So we can correct it with the help of endo and perio interventions. So assessment of endodontic treatment. So always remember, whenever we don't have a healthy tooth, we can go with an endodontically treated teeth. But before we start with any selection, we need to make sure that there is three-dimensional fluid impervious seal. If you see over here, there's a gutta percha which is not extending up to the apex, whereas in the next picture you can see it is extending up to the apex. And meanwhile, we can see there is a small amount of blackish line, that is the radiolucency over here, that indicates there is no proper seal. Whenever there is no proper seal, there could be bacterial invasion inside. Over a period of time, the patient can still have pain in the abutment teeth. And second thing is the most important whenever you do any tooth preparation for young adults. Always remember, young adults, the pulp horns are very much high. So we cannot always advise them to have a crown sooner unless they have a root canal done or root canal was done for the patient. So fixed partial dentures, etc. is not advisable at an early age because of very high pulp horns. So what we can usually do is, like, over a period of time, this pulp horn will be comparatively subdued because of the presence of secondary and tertiary dentin deposition. Automatically the FPD can be very much good. Now, whenever you do any fixed partial prosthesis with the pulp horn being high, even if you're not involving the pulp horn, the restoration would be close to the pulp. So whenever you do any cementation, the cement can percolate into the pulp and cause some amount of thermal or chemical injury to the pulp as well. So I spoke to you all about the crown, the root, the pulpal status. Now I'm going to talk to you all about the periodontal health. Periodontal health is very, very important in any prosthesis or in dentistry as such, if I could say. Because whenever you have a good periodontal tissue, it will make sure that the bone, the soft tissue, everything is very well anchored properly in its place. Whereas the foundation of all the tooth is dependent on the periodontal area. Suppose whenever, now we need to check whether the periodontal areas are healthy or not. What do we do? The first thing what we do is we take a probe and run around. So when we take a probe and run around the sulcus of the teeth from one end to the other end, at one, if there is a pinpoint bleeding, that is referred to as grade 1 bleeding. If there is a small line passing, that is referred to as grade 2 bleeding. If there is a triangular like space filled with blood, that's referred to as grade 3 bleeding. And if there is a drop happening over or fluid getting more exaggerated, that's referred to as grade 4 type of bleeding. So whenever in grade 1, 2 and 3 we can still manage it, grade 4 needs a bit more of periodontal intervention. So bleeding comes referred to as inflammation which is present in the tissues, thus the restorative procedures are difficult to carry out. Suppose we did a tooth preparation and there's a lot of bleeding. If you're applying to capture an impression, the impression doesn't come properly because the impression material doesn't flow in there, because the blood is going to stop it from entering there. And if you do that, we might get a false margin, and finally we plan a prosthesis. This prosthesis is not going to sit properly. Ultimately, there could be a gap between the crown margin as well as the prosthesis, and then it could lead to sensitivity, pain, or it can have a little bit of plaque accumulation and over a period of time calculus accumulation as well. Bleeding from the pocket. Pocket is nothing but ideally it's around 2 mm of sulcus which is there around the teeth. If that part is if that part is overcome by the periodontal infection, it will be very deep. The sulcus depth would be around 3, 4, 5 millimeter. That is called as a pocket. Now these pockets are to be taken care of. I'll be talking to you all in a while. So How do you make sure that we measure the pocket? There is your 3D probe which is used to check the pocket depth, and these probes are color coded. They have a rounded tip that's 0.4 millimeter from there, and then there is 3 mm of band which is color coded to understand how much of depth of periodontal pocket is there. So how do you do pocket? We check bleeding. We could do of the bleeding of gums. We could do it by running the probe around the soft tissue, that's it gums. Whereas if you have to make sure the pocket, if it is proper or not, if it's existing or not, we need to run, or we need to walk the probe. Walk the probe in the sense, we take the probe, put it over here, then take the probe, put on the next surface, then we take the probe, put on the other surface like distal portion, buccal portion, mesial portion, etc. As we keep running the walking the probe, we understand how much, which area the depth of the pocket would be, because pocket would not be uniform everywhere. Some places the pocket would be comparatively more deeper, sometimes some places it could be comparatively shallow. So what's the significance of this pocket? Pocket with the base at the cement enamel junction indicate a hyperplastic tissues. So there are two types of pocket. There's a false pocket and a true pocket. Here if I take a probe, and if I periodontal probe, and if I make sure, if I run walk across, we can get to know whether this is healthy tissue, which you can see from here. If anyway above 2 to 3 millimeter, if the probe enters inward, it is referred to as true pocket, because the gums are at its regular place. Whereas over here, if I take a probe and keep it, the cement enamel junction, everything is fine, but there is exaggerated or hypoplastic growth of the soft tissue which is happening coronally. This is referred to as a false pocket, or is also called as a pseudo pocket. So false pocket happens whenever you take any drug induced periodontitis, or it can happen when there is improper oral hygiene, etc. So what are the methods how you can correct it? Whenever you have an hypoplastic tissues, we intend to make sure that we remove the hypoplastic tissue with the help. First thing, to avoid whatever the medicine is taken. Once you remove the medicine out of picture, the stimulus is not there, the soft tissue goes back to its original position. Second thing is doing a proper scaling. When you do a proper scaling, the irritant or the infected gums come back to its original position. And third thing, if you still cannot manage with all those things, we need to do something called as gingivoplasty. When you do that, we are making sure that we are giving those areas of the gum accessible for proper oral hygiene purpose. One more important and foundation of any prosthetic treatment is never do any prosthodontic treatment unless and until the periodontal and the pulpal issues are sorted, or it is brought back to its optimum. So this is what I mentioned a while back: subgingival scaling, that is cleaning of the tooth; curettage if the subgingival calculus is very deep near the pocket; gingivectomy whenever the false pocket is very much coronal; and flap surgeries in extreme cases. So furcation is very important. Furcation is nothing but, you can see in a multi-rooted teeth. In a multi-rooted teeth, a junction where the two roots meet is referred to as a furcation area. This furcation area is very important because you don't get an ideal situation for crown and bridge fabrication all times. Sometimes you end up having areas of the tooth which is exposed to the oral cavity. These furcation areas are diagnosed with the help of something called as Neighbor's probe, N-A-B-E-R, Neighbor's probe. This Neighbor's probe is kept in the furcation area to understand how deep is the furcation. And how do you manage it? Managing it is very important. We can have something called as, we can first have a good oral hygiene, remove the plaque from the surface, make sure that all the irritants are very well managed, and then we can have a cast restoration which is in the form of the furcation, following the anatomy of the furcation, so that a proper oral hygiene measure can be managed and plaque trap areas are to be eliminated. So what's the biological width? Biological width is a very critical area. It includes the gingival sulcus, which is comprised of connective tissue as well as the epithelial tissue, which is 1 mm as well as 1 mm. This biological width is very important. If it is obliterated, or if the biological width is hampered, or if it is encroached, then starts the bleeding, you get infection, the recession happens, because nature tries to compensate for whatever the problem has happened. So this biological width is very important and needs to be managed very well. And this biological width, if I see from the subgingival restoration, it should not be beyond 0.5 mm from the point area of contact. then if I see in a radiograph, the prosthesis should not be around, at least it should be 2 mm, it should not be close to 2 mm to the alveolar crest. In the sense, when I give a prosthesis, the prosthesis margin ends and the gingival, alveolar crest should be more than 2 to 3 mm. If it's less than that, then there is encroachment toward the biological width. If I have to see radiographically, though it is a very soft tissue area to be identified. Then comes the mobility. Mobility is very important tool. We need to make sure that mobility is not there whenever we do any prosthesis. If we have a mobile tooth on one side, if you have a fixed tooth on the other side, whenever there's a mobility, the movable component moves more, and then it also leads to movement of the teeth which is anchored, because the prosthesis is very much rigid. If that happens, there could be loss of your healthy tooth as well, which is not which should be made sure that doesn't happen and we don't select such an abutment. So how do you identify whether there is any mobility? We need to have a blunt-ended instrument on both the sides and need to move left and right, and then we get to know whether there is any mobility or not. So what are the causes for mobility? It could be injury due to fracture of the roots, it could be facial injuries, it could be any periapical lesion, and which can pull the tooth more coronally. It could be due to a trauma from occlusion, or trauma from occlusion is nothing but excessive force that can lead to breakdown of the periodontal ligament fibers, leading to mobility. And there's periodontitis, which is due to bacterial and microbial invasion into the periodontal tissues. So periodontal ligament area, okay, this is very important area which is comprised of something called as pericemental areas. Whatever is there from the junction of cemental enamel junction going all the way up to the apical area is referred to as pericemental area, because there is a cementum around it. That's why it's referred as pericementum, around the cementum. So this is very important for choosing an abutment. For example, now if you suppose there is a missing teeth, okay, how do you know how many type of, like if there's one teeth missing or two teeth missing, how do you know how much amount of load we need to be managed by the abutment teeth? So this is given by a golden rule by Irving Ante from Ontario, Canada. The person mentions that the sum of the pericemental areas of the abutment should surpass or be equal to the tooth that is being replaced. In the sense, suppose for example, if I have to say 1 2 is missing and there's 1 1 and 1 4. So pericemental area, the pericemental in the sense this root surface area of this teeth and this teeth should be more than that of the root surface area of this teeth. So then this teeth and this teeth can take the load of 1 2. How do you know what is the root surface area? So Jepson in 1963 gave the root surface areas as this one. The highest of the root surface areas is for the maxillary molars, then for the maxillary second molars, and it goes in the similar order. Likewise, for the mandibular arch, the greatest root surface area is for the mandibular first molar, and then mandibular second molar, and the least is for mandibular central incisor. So based on these root surface area calculations, I can illustrate one example for you all. Imagine a teeth has been missed over here, that is the maxillary mandibular first molar. So if you have to use 1 5, this is 1 6 which is 4 6 which is missing. Just imagine if there is 7 and there is a 4 over here. This 4 and 7 has got root surface area, as I mentioned earlier, which is more than that of this one combined. So we can have this FPD which is going from one end to the other end, that is from the premolar to the molar. Suppose instead of one molar there could be a second premolar and the first molar missing. We still can manage it with the help of a premolar as well as a molar, because this premolar root surface area and this one is same, and this one is almost similar. Likewise, if we have a situation where we have 2 premolars and a molar missing, we just cannot restrict ourselves to this premolar and a molar. We need to include even a canine as well to compensate it for the root surface area of one more premolar. That is how we decide how we select a abutment teeth for a fixed partial denture whenever tooth are missing. Now comes the important scheme. So I spoke to you all about the crown length, crown form, crown root ratios. I spoke to you about root length, root form, pulpal health, periodontal health. How do you select an abutment? The final one is evaluation of occlusal scheme. Now we need to make sure there are different types of occlusal scheme, that is a mutually protected occlusion. Now if you are sitting quietly, your mouth is at rest, the teeth are not in contact. But when you start biting, when you bite posteriorly, the anterior teeth are not occluding. Whereas when you get your jaw in end-to-end position, you see the anterior teeth is occluding, whereas the posterior teeth is not occluding. This protection of posterior teeth of the anterior teeth by disoccluding them, and anterior teeth on occlusion disoccluding the posterior teeth because of virtue of protrusion, this is referred to as mutually protection. They are protecting each other. That's the reason it's referred to as mutually protected occlusion. What is a canine guided occlusion? Canine guided occlusion is nothing but during an excursive movement, that is moving from one side to the other side, if canine comes in contact with the lower canine and all the other teeth are getting disoccluded, there is no occlusion between them, this type of occlusion is referred to as canine guide. It happens in healthy individuals where the canine cusp tips are sharp. Over a period of time, this canine gets atrophied more often or less. Then what happens is the canine, it shifts from a canine guided to group function. Group function in the sense, instead of canine and canine coming in occlusion, more than two teeth coming in contact in the posterior region during lateral excursion is referred to as group function because they function in groups. So always remember, this needs to be these type of the mutually guided occlusion, canine guided, as well as mutual protected, canine guided, and group function is very important for success of a prosthesis. If we don't have this, if you don't assess this pre-hand, it could be problematic. It could lead to interference of the crown over a period of time. Then comes the next one, the important part, which is called as occlusal evaluation. Occlusal evaluation is very important because after a person loses teeth, most of the times people don't come on time. So what happens is there could be supraeruption, that is apical or coronal invasion of the opposing teeth, and mesial and distal drifting of the teeth which is adjacent to the edentulous space. So what happens is we need to make sure that if this is not corrected, when the patient is occluding, the first point of contact happens in this area and it can act like an interference, and the entire occlusal area can be mismanaged and can lead to disharmony. So this occlusal supraeruption which is happening, it can be managed in different ways. If it's very simple, we can do simple enamelplasty, that is just to reshape the surface which is coming a little bit below. Second thing is orthodontic extrusion in certain areas when the tooth is more coronally placed. We need to put orthodontic bands and make sure that it goes back to its original position. Then the third thing is, like, some people don't have much time to do that. They would want an immediate treatment. You can have an enamelplasty with a crown on the surface, because if we do keep on doing enamelplasty beyond a particular millimeter, it tends to completely wear off the tooth surface and can lead to severe sensitivity. And last one is root canal and crown fabrication. That is in extreme cases where the furcations are involved, everything is supraerupted into the oral cavity and patient is not ready for extraction. So this is what I mentioned. First one is enamelplasty, then orthodontic intrusion of the teeth back into its original position. The last one is when there is furcation involved over here, we can see tooth is more or less occlusally placed. We can have a root canal and we can make sure that the crown is fabricated. The last portion of my abutment evaluation is a special cases, like where we have a mesial tilted teeth. When we have a mesial tilted teeth over here, this mesial tilted teeth, we do preparation only on the mesial side, very less on the distal portion, and correct it. Number one, if the mesial tilted teeth is extreme, we can have a crown that is called a 3/4 modified crown, where one surface of the teeth is still left, that is the distal portion, and other three surfaces, that is the buccal, mesial, as well as the lingual portion is prepared with the proper retentive groove. So what happens is the path of insertion is same. The basic idea about tilted teeth is this portion and this portion should be similar, so the crown can go inside and come properly, and that is why we have modified 3/4 crown. Now sometimes the tilt is too much, we can have an orthodontic correction of the tooth which is tilted and get back to its original position. So this is how an example is. When there is excessive tilt, if you start preparing the tooth excessively, it can lead to pulpal encroachment, it can lead to pain. So we need to do one of these methods so we can correct the tilt of the teeth. Ideally go for orthodontic correction. If that's not possible, modify your preparation. Then comes the span length and pyre abutment. Now what is a pyre abutment? Pyre abutment is nothing but any teeth which is there having an edentulous span next to it. Like this teeth has an edentulous span next to it, this teeth even has an edentulous span distal to it. So this teeth which is there in the center is referred to as an pier abutment. Now pier abutment, we cannot have a prosthesis like how we have otherwise. Like we cannot have a straightforward prosthesis extending from one end to the other end, because what happens is the patient is biting, there could be movement or there could be lever effect in the pier abutment, and over a period of time the tooth can have some sort of movement as well. So we need to have something called as non-rigid connector. Now what is a connector? Connector is nothing but whatever connects the retainer, that is the one which goes to the abutment, and the pontic which is near the, which replaces the missing teeth, that area which connects these two components are referred to as connector. So this connectors could be rigid or non-rigid. Here in the rigid connector, problems could be more, so we need to do non-rigid connector by providing keyway and a key over here. So when we do that, automatically the stress is broken in between and we can have a proper prosthesis. If not non-rigid connector, we can also have a 3-unit FPD with a cantilever or a suspended pontic over here, so that we don't involve the neighboring teeth. This can happen only when we have an RPD on the opposing arch. Then comes the last one, that's the cantilever FPD. This cantilever FPD is nothing where there's a missing teeth and we can take support. Ideally for an FPD we need to have a posterior teeth and an anterior teeth to give a bridge, but certain situation is not conducive to do that. In those situations we can have a tooth prepared only on one surface, only on one teeth, and we can have a pontic which is suspended from that. The classic example for this type of prosthesis is missing lateral incisor. So canine has got a good root surface area and lateral incisor has teeth which is having the least root surface area. So we can have a canine suspending a lateral incisor from that. So what happens is it replaces for aesthetic, but functional wise you cannot have any contact happening in the teeth. We can have a contact happening in the canine area. Now other situation where you can have a cantilever is a missing mandibular first molar. Suppose there is in those situations we can have a first premolar and second mandibular premolar prepared, and we can have a cantilevered mandibular first molar in shape of a premolar, which means mandibular first molar is shaped in form of premolar and not like a molar. This is done to reduce amount of load which is happening on the surface of the teeth. So to summarize whatever I spoke in my entire talk, I would say like abutment evaluation is very critical and important. Okay. And for that we need to understand what is there in the coronal portion, that is the tooth which we see intraorally, and what is there in the apical region, that is on the root surface area, which is checked with the help of a radiograph. Radiographs are very important. It helps us to understand whether there is periapical infection, pathologies, etc. Periodontal assessment is very important to understand the health of the tooth, and pulpal health is also very important to understand whether we are going to encroach, whether the patient is going to have sensitivity over a period of time, whether there could lead to a non-vitality over a period of time. So we have spoken even about a different amount of which is a different tooth, what is the root surface area, how do you need to make sure that root surface area is utilized very well for the prosthesis fabrication, what is about the arch curvature, how an endodontical teeth is going to function in the oral cavity when it is used as an FPD. And always remember, arch curvature is very important. If you are replacing a canine, maxillary canine, and if there is a lateral incisor and a premolar, we need to make sure that we utilize even a central incisor, because canine lies in an inter-abutment axis, so the load is going to be more. If you don't utilize a central incisor, if you use only a lateral and a canine, it could lead to flaring of the lateral incisor. To conclude, abutment base, the stress of mastication and choice of abutment influences the prognosis of the treatment. The importance of selecting a suitable abutment for fixed partial denture cannot be overemphasized. It forms a preliminary treatment planning for fixed partial dentures, whose proper selection and preparation aids in long-term durability of a restoration. Thank you so much for patient hearing, and these are my references.